Infection is less than 1%. Mercy, that's another reason I love Mercy. It's 0.8%. It will never be lower than that anywhere. It's awesome. But the problem is it's a lifetime risk of 1%. Anytime you have a joint replacement, bacteria get in your bloodstream from time to time, period. When you get your teeth cleaned, when you have any invasive procedures, there's bacteria that leak into your bloodstream that normally your body clears out without a problem. The problem with the joint replacements is they're metal. So the bacteria can stick to them, form a sugar coating, and your body can't get it. So anytime after you've had a joint replacement, you have to, when you go to the dentist or you're getting poked or prodded for anything or you get a bad infected toenail, you got to be really aggressive with the antibiotics to clear your bloodstream so that it doesn't stick to the implant. But still, it's a lifetime risk of about 1%, and extrapolating that out over the typical course of how long a joint replacement is going to last somebody, that's up to 7% now. So this is going to be a big factor in healthcare costs in the future. And we're coming out with implants now. We're trying to figure out how to coat them with antibiotics. I use antibiotics typically in the cement, but that leaches out after 6 to 8 weeks. The actual metal coated with antibiotics is something we're working on now that's not readily available. The typical recovery, the patient, this is another thing, they hurt. Getting a knee replacement hurts. It's nothing like a hip or a shoulder. Because you have to do more side dissection, you have to cut into the patient's quadricep muscle. You have to dislocate the tibia forward to put these parts in. It's a big deal. It's a big operation and it hurts. So that's part of the trend towards trying to do this more gently. Just resurface it, not dislocate the tibia forward, save the ACL, which is which I'll go into more detail with you about after this if you want. That's what I'm working on now. So that the patients don't have as much pain and they have a better recovery. But for now, it's a big deal. So we do multimodal things to make it comfortable for the patient. We give you nerve blocks before the surgery that work after the operation. We inject numbing medicine in the soft tissues around the knee, and we use multimodal pain management. So we've gotten away from using those IV PCA pain pumps and giving you a cocktail of different medicines that all work differently that make it much more tolerable for the patient. So now patients used to be in the hospital up to a week after a knee replacement, not uncommonly. Now people are leaving in 2 or 3 days. It's much, much better. And that is allowing them to function better. So their rehab is better. So there's two things. One is the blood management and one is the pain management that has allowed patients to recover from these faster now. So they're getting out of the hospital in 2 or 3 days, and they're getting kind of their life back by 6 weeks. They're getting off of the cane, they're driving, they're walking around. It used to be a 3 to 6 month ordeal. So it's gotten better, but it really has nothing to do with what we're doing surgically. It's what we're doing to manage the pain and the bleeding. I think the surgery part's coming next. It's on the forefront. So just to be thorough, I'm going to go through everything else, and then at the end, you come back and start drilling me with anything you want. So the meniscal tears are discs of cartilage between the bones, and these are typically torn with a bending and a twisting motion. Squatting, getting out of the car, going to pick something up, and twisting a little bit. As we get older, you lose the water content in this cartilage, and they get stiffer, so they're more prone to tearing. And this is what you see. You either see a radial tear, which is the most common, or you can see this bucket handle tear where it rips around here. This is typically what occurs in a younger patient with an ACL tear. And these can be fixable, where we can actually tack this back together, suture this back together. That hardly ever happens. You see that in a 16 or 18-year-old with a where it tears towards the rim where there's a good blood supply, we can actually fix it. Most of the time, we just trim out the torn piece because it's flopping around in there, it won't heal, and it's irritating to the patient. That's a knee scope, takes 10 minutes, back to work Monday if you have it done on a Friday. So that's minimal downtime to the patient, and that's how we treat meniscal tears. You diagnose them with a physical exam and an MRI. The ligaments, there's ligaments that are inside the capsule of the knee, and there's ligaments that are outside the capsule of the knee. The lateral collateral ligament and the medial collateral ligament are on the sides of the knee. Those are typically torn with a blow to one side or the other of the knee. And we treat these 99% of the time without surgery, with a brace and physical therapy, because they heal on their own. It's just like an ankle sprain. Most of the time we don't operate on ankle sprains because it's the ligaments that are torn that are outside the capsule. So that's what's going on here with the MCL and the LCL. The ACL and the PCL, on the other hand, the anterior cruciate ligament and the posterior cruciate ligament will not heal on their own. So if they're torn in a pivoting motion typically, or the PCL is torn typically in car accidents, where the dashboard hits the knee and it rips the ligament off the back. But isolated PCL tears are extremely rare. I've seen 2 in my practice, ever. It's usually the ACL. Or if it's a major trauma, it can be multi-ligament. But with the ACL, we have to reconstruct that. So we put a new rope through the knee. And we can do that with either cadaver tissue or the patient's own tissue, usually using their hamstring or the center third of their infrapatellar tendon. I tried to pull a picture of this, but I'm sorry I couldn't get it to come in off the internet. But basically between a little bit of bone from your kneecap and a little bit of bone from the tubercle, which is the bump on the front of your tibia, and the strip of tissue in the middle is what we use as graft for this. Or we can use some of your hamstring tendons, or we typically use big sturdy tendons around the ankle from the cadaver. And the decision about what to use depends on the patient. If it's a younger patient, we usually use their own tissue. If it's an older patient, and I don't mean that much older, I mean like upper 20s and on, I think it's better for them to get an allograft or cadaver tissue. It's a much less invasive operation, so it's a faster, immediate recovery. It just takes longer for the body to incorporate into the cadaver tissue than it does into the patient's native tissue. And there's some evidence that they stretch out over time, but we're working on ways to prevent that from happening by using suture to augment it now. So I don't see that anymore. And that is pretty much it for an overview of what we see in terms of knee pain. Tendinitis, the typical one is infrapatellar tendinitis, so pain right below the kneecap is jumper's knee. You see all these guys in the NFL wearing these little black straps down there because they all get it from overuse. But that's pain right there. So we use that Chopart strap as a counterforce brace, and usually some anti-inflammatories and physical therapy takes care of it. Rarely do we need to operate on that unless it becomes very chronic and calcified. Any questions? Yeah? You can turn the lights on.
For surgery with Dr. Whitten on Thursday at Mercy.
Okay.
For a meniscal tear.
Okay.
And arthroscopic surgery. And in this one's AARP, one of the articles is 4 surgeries to avoid. It says knee arthroscopic for arthritis. As a consumer, what do we do?
Yeah, that's interesting because my dad would scope knees routinely for arthritis because it does work. It just doesn't last long. So if you flush the fluid out of the knee, you take the degenerative cartilage out of the knee, you take the degenerative meniscal tears out of the knee, the patient will feel better most of the time, over 90% of the time. It's a question of, does it last them 6-8 weeks, maybe 3 months, maybe a year? But before we had these viscosupplement injections, anti-inflammatory injections, and he was scared to death of putting a knee replacement in somebody who was young, he would do knee arthroscopy, and sometimes people would have multiple arthroscopies. But then there was a couple articles published by a Texas VA, and there was one out of Canada that showed that there was no difference in the patient's long-term outcome from that compared to the injections. So the insurance companies got a hold of this and started nixing arthroscopy for arthritis because it wasn't cost effective, right? Because a cortisone shot costs them $150, Synvis costs them $800 at the most, and a knee scope is going to cost them $500 to $700 plus the hospital fee, which is a lot, so that's thousands. So that's what that means. So as a consumer in general, you want to avoid knee arthroscopy for arthritis. But if it's a young